Okay. So we're going to get in. You're going to learn a little bit about the team we have here on the call, learn more even about who Family Care Center is. Then we'll dive deep into the TMS roundtable discussion with 3 panelists that you see here. Please ask us any questions throughout the entirety of the webinar in our live Q&A button there at the bottom of the screen. We'll try to answer those on the fly if we're able to get them into the conversation. But don't worry, if we don't, we're going to save them all until later in the presentation and answer those all at that time. So we do encourage you to send questions, anything you want to know about TMS, the individuals on the call, or Family Care Center. And then again, make sure you are staying till the end of the webinar. We have a very exciting giveaway today. We got a brand new set of AirPods Pro that we'll be giving away to one lucky attendee at the end of the webinar. So do stay till the end, and we'll be handing that off there in the later portion of the webinar. Next slide, please, Andrew. So here's the panel, the individuals that are on the call discussing all things TMS. We have Dr. Chuck Weber, founder and chief medical officer at Family Care Center, Dr. Narin, who's here in our Highlands Ranch, Colorado clinic, Wes, our new clinic director of our Round Rock clinic, the first one open in the state of Texas that we're very, very excited about. And then moderating and running the slides, we have Andrew. Without further ado, I'll go ahead and pass it over to the one and only Dr. Chuck Weber and let him take it from here.
All right. Well, appreciate that, Trevor, and appreciate everybody coming on for this webinar and to learn a little bit about FCC, TMS, and also the benefits that we can do as we collaborate with our external providers and our referral sites out there. So we definitely want to be part of that community. And that's really what prompted us in 2016. When I say us, it's myself and my wife, Dr. Narin Weber, the better looking Dr. Weber. And she's a family practice doc and focusing on addiction. We spent about 27 years in uniform in the military, in the Army. And our first desire was really to try to make an impact for our local community. And how can we make a difference? So we started with a handful of people, and then we've kind of grown that to an extensive amount of talent and an extensive amount of different specialties. But the core has always been to try to make a multi-specialty outpatient behavioral health that will be a one-stop shop that'll have different therapists that Wes will talk about a little bit in a second, medication management, and of course, TMS, or Transcranial Magnetic Stimulation. And how do we wrap all those things together, create collaborative care, as well as trying to make that impact for the community. About 2 years after we started, what we did was opened up to all different insurances. So our first was just military family members, veterans, and our first responders. But we really thought it was like even a moral imperative to try and help our community. And so this has gotten to bring an amazing leadership team on board. We have some investors on board, and they've really seen our vision and get behind our clinical mission to go to these other states. And we're going to talk about that in a second. But we really want to approach things in a customized way for your patients, whether you're referring them to us, partnering with us, or just using us for TMS. We'd love to hear more about you, and hopefully we get some more questions with that. All right, so I mentioned some of these services here. Now, we do a multidisciplinary approach. I really did think that we want to take care of all the people. And here, you know, I'd like probably Wes to talk a little bit more about some of these services here, especially at Round Rock.
Awesome. So I have created an excellent team here at Round Rock so far that we have every service line we can provide from young children up to 65 plus. They come with a very diverse background of DBT, EMDR, play therapy, couples and family, marital therapy, focusing on all sorts of trauma, addiction, ODD, anything that you can imagine our team can handle. And so that's what's made it really awesome to come here and to learn from them and be able to have that to be able to best have our community impact.
It's awesome. Yeah, and one of these things with all these different services, what it's done is it's made an impact for that community, and it's allowed us to reach out to make new clinics, right? And that'll be on the next slide. So where we first began was in Colorado Springs, outside Fort Carson, where I retired. And then we really grew from the Springs, and then getting that leadership team on board, really wanted to help the rest of Colorado and Denver. And what it's turned out to be is to be the #1 behavioral health private outpatient that in Colorado, as well as the #1 TMS, or Transcranial Magnetic Stimulation provider in the whole state. And we want to take this expertise now to Texas and Tennessee. And the unique thing about this is we do have about 10 providers that are therapists, all from different specialties, providing those services that Wes was talking about, as well as 4 or 5 medication prescribers, and one will be usually a psychiatrist involved, and then there'll be some mid-levels of physician assistants, nurse practitioners. But the thing is, we can tailor each one of these clinics to what the community is asking for. So one is, Dr. Niran is at Highlands Ranch. There's 4 high schools around there. And so what we've done is try to focus a lot more on the adolescents and the therapists around the adolescents. So one of the barriers of care is access. Access to care is very, very difficult. So we want to provide that access, partner with our referral sites, but also try to create a less barrier. And what we found is when people have to drive less than 30 minutes, they will come in more often. And so this is why we have all of these kind of strategic locations, all made by somebody that was a lot smarter than me that knows how to do all these things. So we have like I said, a great leadership team. Let's talk a little bit more about Texas, since I'm just getting here, although I did deploy with the 1st Cavalry at Fort Hood. So Texas, all right. Can you tell me about Texas a little bit there, Wes?
Oh, we have a very diverse population here. You know, we're kind of halfway between, Fort Hood, Texas, we're slightly north of us, or south of them. We're north of Austin. So a very eclectic group of people from here, from civilians to military to veterans. And as you can see, we're starting here in Round Rock and in hopes to expand to Cedar Park and Pflugerville, in Central Austin. We really want to do, like you said, have those clinics that are really spread out in this area, so you're within a drivable distance to get here and get our name out there. TMS is really needed in our area. It's really not a whole lot of TMS places. And in fact, really north of here where we're at, there isn't TMS north of here. You're looking at Georgetown up to Fort Hood. So it's a really needed area for our population. And so you throw that in with all those different therapies that we do and the medication management. I mean, we take that whole person approach to where we can really help those ones that are in dire need.
Yeah, appreciate that. Yeah, we found these great teams, and each one of our clinics are run by clinicians. And so we are very provider centric here at Family Care Center. What that means is that we want to take care of our employees. We want to take care of our providers, all the admin staff that's associated with that. And what that's done is to kind of create both a great environment and a culture for ourselves. But also, I like to tout a little bit is our team is so great. We have around a 90% retention rate for our providers. And so we really are trying to create that environment that people want to come to, people want to engage in, they want to come to work. We are an in-person, but we do offer telemedicine as well. Yeah. All right, so you don't know about depression. Depression is when you have severe dysbondia or anhedonia, what we call is, or without pleasure, right? So that's just the Latin behind that. And what it is the #1 behavioral health condition probably in the world. It's the #1 that takes away lost work days, has impairments, disabilities, and of course, suicide. Suicide being one of usually the top 5 out of any of the deaths, depending on the age group. And for some ages, it is #1. All right. And so what we have here is, the reason why I started to show this slide is most people do not get help, right? And so what they'll do is they suck it down, they suppress, they repress, they move it out of the way, they distract themselves. We have a lot of distractions here in America, right? And so they're not getting help, or they go to their primary care provider, which my wife is a family practice doc. And so that makes it very, very difficult to try to address all their needs in a 10 to 15 minute med spot. That's another reason why we have hour intakes and 30-minute follow-ups for our med management and hour follow-ups for our therapy. I really think it's important for creating that rapport and making that real connection to make that change that's going to be customized. So if they're not getting help, then what's going on? Well, what's going on here is our suicide rate is very, very high. So in Colorado, we are #8 in the nation. We're El Paso County, where I first started our first few clinics, first 5 clinics were all Colorado Springs, with the #1 for veteran suicide in the whole state. So it's really, really on our mind. But when you look at going here to Texas and also in Tennessee, so Texas, for instance, is 36 in the nation. You're like, wow, that's a lot better. That is still 14 per 100K, right? So 14 per 100K are dying because of suicide. This is still a travesty, right? Is any of those preventable? Could we do something else? This is where I'm talking about that passion, that moral imperative, how we go forward, right? Because if we're not getting treatment, you're not addressing that, then it's probably going to come back. And there's also something called the kindling effect. It's like throwing more kindle on the fire and things get worse and worse and worse. This is where TMS also helps out because it's specifically for treatment-resistant depression. But I think that I can make a case that it should be used as a first line as well. Okay. All right. All right. So why are they turning to TMS? All right. Why are they looking for TMS? One, most people don't know about it, which is another reason why we're doing this webinar. And then the other aspect is that there are a lot of barriers for insurance sometimes. And Dr. Niran will talk a little bit on some of the logistics on what we have to do, but we've also kind of cracked the nut, one might say. We have a way that we can take care of all those insurance kind of barriers, or as many as possible. They still throw up a few that are challenging at times, but what we really want to see is usually at least one failed modality, usually one med. Sometimes it's failing therapy, but usually we can also do this in conjunction with therapy and medication management, right, as we're going forward. And so when people are trying to turn, they're turning for something to find a little bit of hope. And let me tell you a little bit more about the history of TMS and where this hope is based on science, okay? Evidence-based science, I want to say. So this is the great Dr. Anthony Barker. Got to meet him. He's a great guy. So he's still alive. He's still going to the clinical societies and he's still giving briefs. So this is new technology, but it's not that new, right? Kind of created the TMS machine in 1984. It's been studied since the 90s and it's FDA approved since 2008. This is for major depression disorder, treatment resisted, but there's a lot of insurances now that are for OCD. And then the FDA is also approved for smoking cessation and anxious depression. But there's a whole slew of non-FDA approaches as well that we really base a lot of these on the European studies. They don't have as many barriers to some of those studies and some of those indications. They don't have to jump through as many hoops in a lot of those places. But what we've found here, and I'll talk about that efficacy, is that we want to take that customized approach for you and treat the whole person, right? And so TMS kind of began in that 84, but it really goes back a little bit farther because he based it on some physics, right? And those physics are Faraday's law and Maxwell's equation. So before you Google it, I'll tell you about it just a little bit. We're not going to have a big physics kind of lecture here, but what it is a magnetic current creates electric charge. So what you're seeing with this TMS technology is that we're going to have an amplitude measured in Teslas. We're going to have a frequency, right? And that frequency is going to be very specific on the things that we want to turn on or turn off, as well as we're going to have the intervals, right? And so how much of polarization, repolarization that goes on. So we'll talk a little bit more about the science, but in a sense, this is about Teslas, right? All right. Not knowing everybody that's on this webinar, or if you're going to be looking at it later on during this recording, but we wanted to kind of do a whole kind of picture here. All right. So what you can see here is the brain. So the blue portion, this is really what makes us human, right? The human part, the things that we engage with therapy, what therapy can change with neuroplasticity, and TMS augments that as well. So all of this prefrontal cortex, the dorsolateral, orbitofrontal, ventral medial, all these areas are for executive functioning, it's for judgment, it's for kind of processing on what we do with our emotions. The emotions are going to be in the limbic system, right? But how do we actually process this? What do we do with this? What is this frustration tolerance? All of those are processed in the frontal lobe. So when we're going to have some radiographic pictures later on, and what we'll talk about is how can we change these things? Because we take a biological, psychological, social, and spiritual approach at FCC. So the TMS is the biological. Usually we want to reduce the symptoms by meds or TMS and get you into therapy. And what is that efficacy for therapy, if you remember off the top of your head there, Wes, on how things work and what's probably the best evidence base that you can think of?
CBT is going to be the one that works best for our TMS patients, but when we can use a lot of things, but really CBT is going to be the one we're going to go to the most.
Yeah. And have you found any barriers to having any of the talk therapies and using TMS in conjunction with that?
I haven't seen any barrier so far. Anything that I've seen, it seems to be working really well. I mean, obviously there's those one-offs, but really a really high success rate.
Yeah. And this is what we believe too. And so we can use this in conjunction with talk therapy and meds. And I will, truth be told, even though I'm a psychiatrist, I want there to be less meds, right? There is so much over medication going on right now in America and in the world. We want to use them appropriately and we want to use them correctly and evidence-based, but really getting that psychological and getting that into that therapy, you're going to have that durability. And of course, the social is that environment and the spiritual is kind of your own path. You know, what that means to you, but all four of those legs of a chair are going to make a difference for you. All right, so this is a computerized, all right, spec scan. And so what we're trying to look at here, and I didn't give you like a definition, but just to tell you, red and yellow, it means high. The blue and purple and the kind of lower, that means low. Too little, too much, right? But when we really see the brain here on this normal brain, by the way, I've never seen a normal brain. I've just seen people that are depressed or not depressed, right? And so, but in general, when somebody does not have a pathology in mental illness, that far left, right, is going to look like that normal brain. And look at it. We're using all of it. We're using all of it in a specific way. And we're definitely using everything from the front. And where that normal brain size, where you scan, where you see that, that is where your eyes are. That's the front. So I want to affect the frontal. If you look, we're using all of it. We need all of it. But on that next scan, which is very, very blue and very depressed and very hypoactive is what we say. And this is a depressed brain, right? So specifically on the left side, you know, might look on the right, but this is called an axial cut. We're actually looking up. So part of this is just how we do it in radiology and how we, approach these kind of aspects. And so on that right side is truly the left, and it's really, really hypoactive or not, being utilized at all. Now, this could be genetic, this could be environmental, this could be drugs. There's a lot of things that can cause these things. Once again, I still believe biopsychosocial, spiritual, but it's very, very low. And so how do we affect this neurochemical machine that is our brain, right? How do we affect the electricity? How do we affect the neurons in there? And this is where TMS and talk therapy and really not meds. Meds are more of a duct tape. It's the talk therapy and the TMS that really makes a lot of this durability. But going on to that next one is the bipolar. Now, the bipolar, it's once again bipolar. Now, this is not in a manic state, all right? So most bipolars spend the majority of their time in depression, but you can still see it does not look like that normal brain. There is an electrophysiological difference between a normal brain and all of these that are going on. So this is what I really want to kind of drive home and let you all know is how do we change this, right? And of course, the schizophrenic brain, still much different, much more active, especially in that back. It's called the occipital lobe, right? So there's a lot of processing on what they see and what they hear and hypersensitivity, whether it's internal or external, a lot of things going on there, usually associated with hallucinations, right? And then the OCD, obsessive compulsive disorder. You can see compared to that normal brain, very, very hyperactive, especially in the front, so there's a lot of things going on in the ventral tegmental area, in that prefrontal cortex that is too much. And so TMS, remember, turn things on, turn things off. And we're going to see a little bit on just how do we do this. Okay, so we have a coil. So if I said, if we're an electrophysiological machine, okay, if the neurons are having electrical activity, the chemical release and electrical activity, we've made this about 100 billion, right? 100 billion at least, right, of neurons that are going on, which is much more than the population of the whole world, right? But think of all these neurons in each one of your head. Some are not working and some are. So how do I affect them? Well, when I put two coils together, it's called a figure 8. In one of our machines, this is a mag venture, it creates a focal point. And that focal point is the quintessential or the specific area where you have the most magnetic pulse. And I can direct this, instead of doing something called electroconvulsive therapy, which is an electrified field for your whole brain, I'm going to actually direct it into those parts of your brain that are not working, that was shown in that other slide. And so it's going to deliver a magnetic pulse, and that goes right through the skull. You don't even have to, you don't need anything. It actually goes to that skull, and then it takes advantage of that Faraday's law or Maxwell's equation, create an electrical charge. So if the area is not working and then I turn it on, this is going to be where we see the biggest change, right? I'm actually making electrophysiological changes in your brain. Now, what if it's too much, like the OCD or the anxious or PTSD? There's different frequencies in different areas of your brain that we can actually focus on and actually inhibit or lower down those fields, right? And so the magnet is amazing. So how do we make it customizable for you? So we do something called a motor threshold. So every part of our brain, there's somebody that's studied it a long time ago, and named different things, and most of it is going to be in Latin, right? And it's just actually describing where it's at. It's kind of interesting. And most of med school is just kind of learning a new language or remembering Latin and Greek and putting it together, and then that's a diagnosis. And a diagnosis is really a constellation of symptoms. I'm digressing a little bit, but in general, what the motor threshold is we're going to make it very customizable. Everybody's different. Wes is different than me, and I'm different than Dr. Narin. And so what we do is we send a pulse, a test pulse through basically the area of your brain that is your finger and thumb. And we actually move it. So if I can move a body part, then I can definitely create a neuronal action potential, what we call them. And so I'm making depolarization, I'm making that neuron move, right? And so then we find the specific number, the right amount of Tesla for you, right? We want to use the least amount too, right? So we want to first do no harm. Then we do test pulses into the front. Dr. Niran will talk a little bit about some of these logistics, but it kind of freaks out some people. But it's not freaky. There's no pain associated with it. Tell people it's a little bit weird and annoying. There's a little bit of tapping that goes on, but it's very, very safe. And we do test both sides because there's a lot of people that have these comorbidities that we need to address everything that's included that you're bringing to us or referral partners are bringing to us. We want to make sure and address all of those. So before I head it over to Dr. Narin to talk about the logistics, I was wondering if there's any questions or anything I can clarify.
Yeah, Dr. Weber, there was a question, how long does TMS last?
Yeah, that's a great question. And so we'll talk about the logistics, but we need about 6 to 8 weeks for there to be treatments that are going on, about 20 to 30 minutes. So I don't want to steal all of Dr. Narin's thunder. But in general, what that does is that usually creates a huge amount of efficacy, right? And we'll talk about the efficacy in a second. Here, but it lasts for 6 months to a year. And then I have patients now, I've done over 800 mappings and remappings, the most in Colorado. And sometimes I've never seen patients again, or I see them in 1 to 3 years, or sometimes we have to use a tapering protocol. That means we do a little bit at a time, we hold some back, just kind of see how the patient is doing. And so what I usually see is 6 months to a year. And then that your symptoms are either not in remission or they're actually reduced significantly. I'm going to talk a little bit about that efficacy.
We have one more question.
Yes, sir.
How do we refer to TMS?
Yeah, so we have another slide at the end, but how you refer to TMS is one, we have both our website where you can have a direct link where you can actually kind of fill out a form and say, hey, I'd like a consultation, a no cost consultation. I'd like to learn more about this. We have a phone number as well that we will display and put out. And so we can do it in person at our clinics. We can do it through the web, and we can also do it through the phone as well. We're not quite there, but we are going to have a time where we're able to kind of make our own self-appointments, and we're working on that right now. So web, phone, or in person, and get that no-cost consultation. All right, so all of these things putting together, how does this work, right? And so how it works is pretty good and a lot better than my meds, right? My meds work about 55% of the time. They work a lot better in conjunction with therapy when we do these things together. And you can look at this as far as what that pharmacotherapy kind of looks like, right? It's very, very low. And I said that 55%, that's the best that we ever do with meds, right? And even with TMS, about 60, 63. Now, these are for the meta-analysis. We have the, we have the study that's down below right there that we kind of referenced, but there's been hundreds, probably thousands now of studies, but about 100 meta-analysis that brings all those studies together and looks at that. Now we have years of data as well, and what our response rate is, and we measure this. We do measurement-based care at Family Care Center, and our response rate is 78% is about where we're hovering. And so that means probably look at all those numbers that are on that slide. It's better than any med that I have. It's better than when I put a lot of things together. But by the way, that 78% is coupling with talk therapy, right? We're doing those together, right? In conjunction, and we're collaborating and talking. And of those 78%, we have about 35% that are in remission. What that usually means is their symptoms are down, right? So much so that there's no cure for depression, but it's definitely a reduction, so much so that sometimes we reduce meds, we reduce the dosage, or we get you off meds completely. And that's really, really what my hope is to reduce suffering, reduce that med kind of impact, and then get you into therapy and get you going.
Dr. Weber, could you answer a question regarding which major insurances cover TMS treatment?
Yeah, sure. Most all of them cover TMS, right? And so all of them have a little bit different criteria. The FDA is one failed med, and then you can get into TMS. I think Medicare is the only one that has that same kind of criteria. There might be Anthem or Aetna. Maybe Andrew, you can help me out with that. That is just that one med and as a failure and a diagnosis of major depression disorder. But some are 2 to 4 failed meds, but all insurances have some kind of coverage for TMS or a criteria. They've all recognized the great impact it can make. There is one caveat that I have not seen Medicaid in any of the states. So state kind of insurance is the only insurance one that FCC does not take, as well as it's the only one that does not have a TMS criteria or an authorization process. Okay. So without further ado, we will kind of switch over here and have Dr. Niran talk a little bit. He's an expert with TMS. He also had a business before coming to FCC. He's a great partner. He's the vice chair of our clinical governance board. And take it away, sir.
Hello, everyone. I'm Narin Wongngamnit, and as Dr. Weber said, I work out of the Highland Ranch Clinic in the southern Denver metro area. And I'm glad to be here because talking about TMS is one of my more favorite things to do. And if you're like me at all, you've probably enjoyed hearing the science behind it. Now, what we have to talk about is how can we get the science to benefit a patient? And so part of that is understanding what they go through and what the process looks like. And so I'm going to start there and walk you through what that looks like. Dr. Weber talked about the free consult to ensure that people are appropriate for TMS. After that is done and you're starting your process, the very first step is very individualized. Every step is individualized, but it starts right from the beginning. And that's with mapping. That's when your provider is going to be looking for a very specific type of body movement that you evoke with the magnet. And we looked at that magnitude in a previous slide. And that gives us a visual response to confirm that we know that your body will respond to that amplitude of or that intensity of the stimulus. And so what we also know is that amount gives us a lot of cushion because we don't actually have to go that high in order for the brain to react to what we are applying to it. And that might come in later. And so the very first step is mapping you and finding out exactly where the treatment location is and where the motor threshold or what the intensity of the motor threshold actually is. And so after that, treatments, if you were to rely on the data from from many studies looks to be rather constraining in that there's 32 to 36 sessions at 5 days per week. Now, if we look at it each person and keep in mind that at the very heart of that person is a biopsychosocial and spiritual type of foundation, we know that life happens and that some people can't make it in 5 days a week. We've also done enough treatments throughout the Family Care Center and myself in previous organizations that we know that 1 to 4 treatments per week is still an acceptable amount. People can still get better. We also borrow from a lot of ECT literature when we tailor the end of their treatment and start to wean a person off of daily treatments. Again, that is a collaborative effort between the provider and the patient, and it's informed by their response rate, and what they're comfortable with. Now, of extreme importance is none of this hurts the patient. If it hurts, something is wrong and it will be rectified. We'll hear a lot of adjectives. I've heard people say that the tapping sensation feels like an angry woodpecker, and I've heard some say it feels like a pretty happy woodpecker. I've had some patients say that as soon as the sensation appears on their head, they have the desire to just sit back and relax, and other people say it just feels odd. But importantly, we do not want to hear that it is painful, and if it is, we will address it. And to date, I have not yet seen a patient not be able to get fully mapped or undergo treatment because of pain. Now, when we talk about treatment-resistant depression, which is what we think about when we look at TMS, even though those of us who have been doing it for a while and looking at the data think it should be a first line as well, we know that treatment resistance is what is FDA approved for and what the research has done. And when you think about other treatments for treatment-resistant depression, you think about things like ECT. And here is where TMS shows a lot of advantage. First, there's no restrictions on activity. There's no time off work. We have many patients who come here during a break or a lunch break, and they drive back to work after treatment. If there are any residual symptomatology after the treatment, it's generally very mild. And so this doesn't take a person out of their life and apply treatment in a bubble. Rather, this is treatment within the construct of their life. And as we talked about before, treatment-resistant MDD is what most of our patients are getting TMS for, and it is covered by all commercial insurances, Medicare and TRICARE. And on select insurances, OCD and smoking cessation may be covered as well.
Dr. Pardon me for interrupting, but we had a really great question that I wanted to interject quickly. Since TMS is non-invasive and it is not a painful procedure, can it be utilized with adolescents?
So whether something can be and whether it's reimbursed to be are kind of separate questions. So the FDA has cleared this for adults, but there is a healthy amount of data saying that adolescents can be treated with it. And so the answer from an evidence-based perspective is yes, adolescents are not ruled out just because of their age. There are extraneous financial considerations that have to be taken into account at that point. Can we go into the next slide? Thank you. So currently at FCC Clinics, we are covered by 2 main machines. And these include the MagVenture, which is probably our workhorse at the moment, and BrainsWay, which is generally represented at a regional level. And the reason for this is we want to respond in the most prudent manner to the needs of the community. And the MagVenture is designed as a workforce with a large degree of coverage for the disorders that we most commonly see. And Brain's Way adds a special niche in that it's a deeper coil. It has FDA approval for things like OCD, and it offers a secondary modality in case a patient is not responding to our first-line treatment. Importantly also is, I've been at FCC long enough now to know that there's constant reevaluation of the needs of the organization and the needs of the communities it serves, that there's always consideration of what machines should we add or what machines should go where. Again, this shows that the FCC is really responsive to the community's needs and tries to meet them as best we can. Next slide, please. This slide shows you that even though we use the word TMS, TMS is not all the same with all machines every time. And so the brain operates on various frequencies. There are a multitude of different places that we can target for different disorders. And thus, there are different coils that can be applied. So when you have a patient who comes in, we may, in some situations, let's say to target OCD, choose to use an H7 coil. Or we may choose for major depressive disorder to go with a traditional figure 8 coil to allow them to be treated at the clinic closest to them. And so we have to keep in mind that not all TMS clinics are going to be outfit with as much versatility as you might like them to be when you're making a referral to them. And FCC has their bases covered with a lot of crossover with the coils that we tend to use. Next slide, please.
All right.
So one of the most important things that I think patients need to hear, and what people who are going to refer their patients need to hear, is that TMS is safe. Of the major side effects that you may worry about with TMS, and the one that I think a lot of media kind of talks about is a seizure potential. That is a fraction of a percent chance of happening. And it's usually related to a direct stimulation. So turning off the machine generally is all you need to do to respond to it. And in retrospective type studies, they've noticed that this is most common when patients have failed to talk about big changes in their life. They've elected to stop drinking cold turkey, or they've stopped taking a medication. And so here at FCC, we have a check-in every single time that they come in to make sure that nothing has changed in their life and to mitigate that risk as much as absolutely possible, knowing that its baseline risk is very, very low. If we can compare it to drug therapy, I think everyone here who has worked with patients who are on drugs have seen probably everything that is listed on this slide: insomnia, blurred vision, dry mouth, fatigue, weight gain, nausea, GI distress, sexual dysfunction. And sometimes it becomes a game of, you have it, is it worth being on this pill? As opposed to something like TMS, where we have perhaps transient scalp discomfort or slight post treatment headache for the first week or so, with no other real side effects and a lot of potential benefit. In fact, a potential for benefit that outweighs that of drug therapy once you have hit the 2 or 3 drug trial mark. Next slide, please.
Dr. W, we had another question, if you wouldn't mind answering this one, regarding substance abuse. Is that a disqualifier for TMS? Despite alcohol, there are other substances such as marijuana or methamphetamine that may play into factors for patients who are interested in TMS?
So I believe that there are a couple insurances that will say that they won't allow you to go forward with active substance use. Outside of them, I consider it to be a very individualized type of discussion with the patient, talking about the risks, the benefits, and what is known and unknown about what may happen. Like, for instance, we know that heavy cannabis use may blunt the effects of TMS. Does that mean it's no longer worth doing? I would argue not. But I think that it warrants a conversation with the patient about their use, what they're hoping to get out of it, and what other modalities of treatment we can wrap around to help them meet their goals. So the ideal candidate, at least one failed med, but most insurances, just keep in mind, will require for 2 to 4 failures and possibly some time with therapy as well within the episode of depression. We have seen people who aren't able to effectively undergo therapy because their symptoms are just intolerable. Those are candidates as well. I think we have to keep in mind that on certain machines and in certain coils, there are FDA approvals for OCD and smoking cessation, but the non-FDA uses include help with PTSD, general anxiety disorder, phobias, neuropathic chronic pain. And when we do this with patients, we have a very, again, an individualized discussion with them to talk about what is FDA approved, what is not, and what the data supports using, and what the risks and benefits of that individualized treatment modality might be. Okay. So, Dr. Weber, would you like me to continue with some stories here? Start us off?
Yeah, you can actually do the case presentation. I've got a few hundred if you don't have one on you there.
So I know that we want to leave some time for some questions at the end, so I will be kind of brief, and I'm going to present just two very common patients and what the results were. So the first is a middle-aged woman who presented to the clinic, and she had been under med management for some time with pretty much 20 years of therapy. And her interactions with the clinic were strained. Her depression manifests as an irritability. Front desk staff didn't necessarily, that they knew that when she came in to expect that there may be some difficult interactions. And no one could really get to know the real her. When we started TMS, it wasn't even 2 weeks in, and everyone that I passed in clinic started commenting on noticing the difference. And it wasn't long after that she approached us and said, I can't believe how much better I've been, and my family cannot believe how much better I have gotten. I believe at the end, she went from a PHQ-9 of probably in the low 20s, if I remember correctly, to under 5. So she had total resolution, statistically speaking. And she still pokes her head in when she comes in for med management and smiles and says how thankful she is to have gotten the TMS. So that's one patient. And another is another middle-aged woman who presented, and she had anxiety and depression, but she also complained about 2 to 3 debilitating migraines per week. And this is a high-functioning individual with a high-stress job, lots of responsibilities, and she was finding herself so anxious that she couldn't drive, partially because the migraines happen while driving so often, and partially because she was just now, the train tracks had been laid in her brain to become anxious. And so she started noticing effects from TMS almost immediately. By the end of our treatment with her, she had 1 migraine episode in the past 6 weeks. down from 2 to 3 every week. And again, we talked about the FDA approval, or not a lack of approval for this, but we're able to integrate what evidence-based interactions we could into her treatment of depression and anxiety. And her depression also met resolution. She was under 5 by the end, and I believe her anxiety was near 0. So those are two pretty classic patients that I think people would see that had a very strong response to TMS.
I have a question that has been placed that I would like one of you to answer, please. The question is regarding other technologies that have been used for treatment of major depression, such as deep brain stimulators or vagal nerve stimulators. Can you compare the efficacy rate of TMS versus these other technologies and address what the advantages of TMS may be over these other technologies?
You want me to go ahead and Dr. W?
Sure.
Okay. Yeah, you definitely augment me and help me out with so the last one I think was a 2019 study that I looked at for comparison. Now, one, the vagus nerve stimulation and deep brain stimulation are invasive, right? I mean, we have to actually break the skin. We have to actually kind of go in and put some things in there, right? And so this is completely different. So it's not necessarily orange or apples to apples, you know, but there is a lot of treatment and there's a lot of literature to show that some of these things, mostly on both deep brain stimulation and vagus nerves, a lot of studies with seizures, right, for epilepsy and how we can kind of treat that. But there is a growing literature for depression, right? And that the problem is one, you're putting something in your brain, right? Or you're putting something on your vagus nerve. And I think the last time I looked at things were around 55 to 60% for an efficacy. So we have something that's invasive, but we have a lot lower than something that's non-invasive. The good thing is with both the vagus nerve and the deep brain stimulation is that once you've done it, there might be a little bit of maintenance. There's some other things to do, but it's kind of done, right? Might be some tweaking. There is some aspects of going in and getting some follow-ups. So the only thing I would say that might be a pro for that would be that, you know, you're not doing 5 days a week for 6 weeks. But when we talk to these people, you know, they've had years and years of depression. So to do something for 6 weeks is difficult. We've all made New Year's resolutions, right? But for the most part, it's very, very, it's very reasonable to say, hey, I need 20 to 30 minutes for about 6 weeks to really get you better. And the stories that Dr. W was saying was like, wow, they are changing their lives.
I'll just tag on a little bit too to add my 2 cents. So in a previous life, I was a interventional pain management doc, and so I put in spinal cord stimulators and I did a lot of fun things that are pretty analogous to some of these procedures that you're talking about. Now, the very first thing that we worried about when we were the interventionists was the anesthesia. The anesthesia risk is actually higher than most of the procedural risk. With TMS, there is no anesthesia risk, 0. And so you take one of the biggest things off of the block right there. Secondarily, no post-infection rates. And because interventions are more difficult to recruit, the body of literature is smaller. And so you're comparing something with a very robust history, and I wish I could quote the number of millions of treatments that we have underdone against a very niche type of intervention. And so it's very hard to do a direct one-to-one comparison justice, given that they are on different risk stratifications.
Great. We have a couple more minutes for some quick questions, and we have a really good question here that I wanted to get to. As a referring provider that is outside of the family care center, what sort of communications could they expect?
Yeah, well, pretty constant. One, we need that referral partner and we're going to make sure and take care of them. I have a saying, we're going to definitely use FCC like a buffet, right? Whatever we can do to help the community, we're going to do it. If you're seeing them for med management and they need some talk therapy, we're going to bring them to Wes and the team, right? If you're doing talk therapy and need meds or TMS, we're going to make sure and help that out. And so what we do is, especially the biggest question that comes up is, I'm a med provider, I send them for TMS, and how do we communicate? One, we have these things called TMS care coordinators, and we also have a care collaboration group nurse case manager. And so what we try to do is send those notes and have that communication going pretty constantly to make sure that, one, you are aware of what's going on with your patient and also when to possibly taper medication. And as Wes had said, and the literature backs this up too, is there is no contraindications with the talk therapy, doing the talk therapy in conjunction with TMS. We'll still communicate and let you know how things are going. And we definitely want to create that partnership with our community. And so we have 2 different venues for that, as well as a patient portal. And we can also do memorandums of agreement, right? So that, especially if we have referral partners that we're constantly kind of doing, continuity of care is a great way that we can kind of, bridge that gap to make sure that we have those communications. So we take it very, very seriously for our referral partners. If you're seeing them for talk therapy or med management and just need TMS, that's what we'll do. And we'll just communicate with y'all.